Welcome once again to the medical student in College of Medicine and College of Pharmacy whom join us and interesting in this series of lecture in the physiology of cardiovascular systems. Today we'll summarize the last two lectures graphically and hemodynamically. As we said, the cardiac cycle have phases. To start with the atrial systole, it means at the end of diastole. You remember that the beginning of diastole is the opening of atrioventricular valve and passive filling of the ventricle, while at the end of atrial systole is the atrial contraction, depolarization and contractions. So prior to atrial systole, blood has been flowing passively, as we said, is a passive filling, rapid filling. But the last phase of diastole is the atrial systole. During atrial systole, the atrium, here the left, here the right, is contracted on top of the volume in a ventricle, extra volume in a ventricle. As we said, it's 20% of filling, with only small amount of blood. Atrial contraction is complete before the ventricle begins to contract, before that the ventricular systole. The pressure and volume, look, the A wave, as we said, occurs when the atrium contracted. We see it in the venous pulsation, in the internal jugular vein. This is the yellow color. This is the A wave. Yellow color A wave due to that the atrial contractions. While the blood arriving at the heart cannot enter the atrium, so it is a flow back up into the jugular vein due to that this pushing of the blood due to the atrial contraction, causing the first discernible or seeing wave in the jugular venous pulse. Atrial pressure drop when the atrial top contraction, so that the atrial pressure, it will be dropped down there. The pressure, it will be dropped down due to the emptying of atria. During atrial systole, the atrium contract, tops of volume of ventricle with only small amount, as we said, in 20%. Atrial contraction is complete before the ventricle began to contract. What ECG finding in atrial contraction? As we said, an impulse arising from SA node result in depolarization contraction of atrial right and left atrium and give us as a P wave. So the P wave is due to the atrial depolarization. And the PR segment is electrically quiet as a depolarization proceeds the AV node. This is the period at which that the heart is have a fraction of millisecond to fill that the atrium. This brief pause, as we called previously in action potential, as the compensatory pause before contractions allow ventricle to completely filled with the blood. What the heart sound we heard in atrial systole? Fourth heart sound. What this fourth heart? Please see. First heart sound as we need due to the closure of the atrioventricular valve, what called at the beginning of systole. While during diastole, closure of semilunar valve give that the second heart sound, which is two components, pulmonary and aortic. Aortic before the pulmonary. Now to the S4. What's S4? S4 is due to the atrial contraction near the S1, what called parasystole, but at the end of diastole. We say that the atrial systole at the end of diastole. So near the S1, which is S4. When we see the S4 sound, usually pathological, almost always pathological. The fourth heart sound is abnormal and associated with the end of atrial emptying due to the atrial contraction after atrial contractions. It's occur with the when the atrial contract against abnormal stiff ventricle. The contract of atria normally, if the normal ventricle there is no force, S4. But if abnormal, what mean abnormal? Like hypertrophy, hypertrophic congestive heart valve, massive pulmonary embolism, tricuspid incompetence or rigor cor pulmonale. So that when contracted against stiff, give the S4. So that now is the 3 sound. What remain is the S3, we will come to it. So this is the end of the atrial systole. Come to the next phase, isovolemic or isovolumetric contraction at the beginning of systole. So in isovolemic contractions, the atrioventricular valve close at the beginning of, due to that the high pressure there and pushing AV valve. Really, the AV valve, when the ventricle filling slowly, so this van of that the, atrioventricular valve, it's coming near to be closed. But at the beginning of contraction, it is closed abruptly, but not bulging too much, as we said, from the papillary muscle and cord tendon. The electrical ventricular systole is defined as, now we see, QRS complex, and the end at the beginning of the Q and end of T wave, what called QT interval. This is electrical ventricular systole is by QT interval by QRS complex. What mechanical meaning of ventricular systole is defined as interval between closing of AV valve and opening of semilunar valve. The interval between this is ventricular systole, while electrically is defined interval between QRS complex at the end of T, which is a QT interval. So what the pressure and volume in isovolume? The AV valve closed, while the semilunar valve closed too. So AV valve closed there, and semilunar valve still closed there. And the red line, this is that the AV valve closed, while this is that the green line, semilunar valve is closed. And that as a ventricle contract isovolumetrically, what does mean? So the volume is no change. This is the volume is a wide. Is no change in this period. But so that this is a contraction, volume no change, but the pressure we see it from the nearly that the 0 or 1 until reach to 80 or more. So their volume doesn't change, which is the white color, while the pressure inside approaching the pressure in aorta, which is that the, and this is that the pressure, this aortic pressure, and this is that the rate is the rising of that the ventricular, the pressure inside the ventricle. So in isovolemic contraction, 4 valve close, volume no change, pressure rapidly increase near the pressure in the great vessels. What happened in ECG, as we said, electrical impulse propagate from AV node with some delay, as we said, through the His bundle Purkinje system to allow ventricle to contract from apex of the heart toward the base of the heart. And this is a QRS complex, as we said, due to the ventricular depolarization. P wave due to the atrial depolarization. It is large, so it is mask the underlying atrial repolarization. As we said, atrial repolarization not seen in the surface ECG record because this is large QRS complex and this is negligible electrical activity, so it is masked. Is there any heart sound in the isovolemic? Yes. What called first heart sound? Look, is it due to the closures of AV valve associated with the turbulence of the blood and that the valve leaflets moving due to the pushing of the blood? So it is S1 is that due to the beginning of the ventricular systole, while S4, as we said before, S1 due to the atrial contraction, atrial sound, parasystole near the S1. Come to the next phase is rapid ejection, rapid ejection of the blood. So at this moment, the semilunar and aortic valve open due to the high pressure there built up in both at the end of isovolemic contraction, pressure more than the aorta and more than the pulmonary. So pushing this semilunar valve to open and the blood rapidly ejected. As we said, about 70% or more than 70% of blood ejected at this phase. What happened in the pressure and volume? While the ventricle continue to contract, the pressure in the ventricle, as we said, this red one, exceed the pressure in aorta and pulmonary arteries, which is the green one. And so force the semilunar valve to open. And the blood exit the ventricle and the volume in the ventricle decrease rapidly. See that this is the volume due to the first ejection of blood is rapidly drop down, but not completely. This is about 70% of the blood is emptying in this rapid phase of ejection, while 30%, as we said, in the remaining 2/3 of the middle and late third of the ejection of the blood. So as more blood enter the arteries, pressure there built until the flow of the blood reach a peak. So the pressure in the arteries, we will see, even reach to 120 when rapid ejection of the blood. So the C wave, as we said, is there due to the early phase of due to the ventricular ejection or the systole. This is a mechanism, as we said, some blood is passed to the atrium, or that the tricuspid valve is pushing into the right atrium. Normally, this is not discernible, not seen, but in the venograph, it was seen. In jugular veins, not venous pulse, not seen. Right ventricle contract, push the tricuspid valve into the atrium and increase the pressure, creating a small wave into jugular veins. It's normally simultaneous with the carotid pulse. Well, the ECG, in this, there is no deflection in the rapid phase of ejection. What the heart sound, you will not hear any more sound in the rapid phase of the ejection. And that the reduced ejection, the next 2/3 of the cardiac, ejection of the blood. This is near the end of systole. Near the end, most of the blood is pushing. What remains is that about 30% of ejected blood into the pulmonary. And at that time, look to that the blood continue to filling of left ventricle from superior and inferior vena cava, other sources, to filling at the time of ventricular. The atria are in diastole. At the end of this phase, semilunar aortic pulmonary close. Why close this valve at the end of this? Because of that the pressure is high, is 120, more than pressure which is a drop in the ventricle. So the blood try to back into the ventricle. As we said, that semilunar valve function is to prevent backflow of blood from great vessels to the ventricle. So it is a snap and close. And also second mechanism, these arteries, aorta and pulmonary, are the distensible arteries and the elastic arteries. So when they distended and they recoil, this recoil increase the pressure in the blood to return back to ventricle. That is why force the semilunar valve to be closed. What the pressure and volume after the peak in the ventricular pressure, which is red there, and at the green, it was that blood outflow, flow out of ventricle decrease, and ventricle volume decrease more slowly. So the first ejection C is a rapid, while the next phase is the slowly reduce. the volume. When the pressure in the ventricle falls below the pressure in the arteries, blood in the arteries began to flow back, as we said, toward the ventricle, causes semilunar valve to close. This marks the end of ventricular systole mechanically. What ECG finding? There is the ventricular depolarization. As we said, T wave is due to the ventricular depolarization. The end of T wave marks the end of ventricular systole, as we said. What the heart sound there? There is no heart sound will be seen at the end of systole. While isovolemic or isovolumetric relaxation, the beginning of diastole. At this phase, at the beginning of this phase, AV valve are closed, while semilunar valve is still closed, so 4 valves are closed, and the ventricle is contracted, relaxed, sorry. We will see the pressure is dropped down rapidly, near that the diastolic level 0, while the volume, see the volume is not more change. The volume change in the rapid filling, then slowly change in the late filling, while during isovolemic, when the ventricle relax and the pressure drop down, the volume not change. That is why it's called isovolemic. Through this and the previous two phases, the atrium is, as we said, in diastole, has been filling with the blood. And this is filling of the blood, we would see, give us that the V wave, which is during the end of systole. This is a V wave. And the V wave is due to the backflow of blood in this closed AV valve. And it is the second discernible seeing wave in the jugular vein. This seen, an AV wave seen, but C wave is not seen. The pressure in the ventricle rate continue to drop down. And the ventricular volume height is not too muchly changed. Is there ECG change? There is no deflection. Is there any heart sound? Yes. The closures of the semilunar valve, as we said, give that the second heart sound, DOP, which is two component, aortic and pulmonary. Occurs when semilunar aortic are closed. It is high frequency sound, high pitch. S2 is normally split because aortic valve slightly earlier than pulmonary. We see two components. Rapid ventricular filling. The next phase is the rapid ventricular filling. When the pressure, as we said, in the atria is exceed the pressure in the ventricle at the end of isovolemic relaxation. So this is force this AV valve to be open and emptying of the blood. Once the AV valve open, blood has accumulated in atria from the rapid into the ventricle. As we said, this is rapid filling. About 80% of the blood is passed in this phase. And what the pressure and volume? Ventricular volume is increased. So start ventricular volume from there, which is no change in isovolemic, to increase. Firstly, rapidly due to the 80%, then it's slowly at the end of the late filling. Is there ECG change? There is no deflection. Is there any heart sound? Yes, this is the S3, what I told you, I will tell you about. This is the fourth heart sound, the other sound, added sound. Third heart sound is usually abnormal, sometimes in children, young adults, but usually abnormal, due to the rapid passive filling. Look, this is the closure S1 of mitral tricuspid. This closure S2 semilunar valve. Due to the S4 near the S1 at the end of the diastole is the contraction of the atria. against the abnormal ventricle, like hypertension or hypertrophy. There is a filling, a rapid filling. In normal heart, there is no sound. In abnormally ventricle dilated or failure, it will produce this low frequency S3, which is after S2 at the beginning of diastole, while S4 at the end of diastole, S1 at the beginning of systole, at S2 at the beginning of diastole, at the end of systole. So S3 is usually abnormal as due to the rapid passive filling. It's occur in dilated congestive heart failure, abnormal ventricle, severe hypertension, myocardial infarction, and mitral regurgitation. And reduced ventricular filling, this is the long phase, what called diastasis. And the rest of the blood that has accumulated in atria during ventricular systole flows slowly into the ventricle at the end of this phase of filling. What the pressure and volume? Ventricle volume increase more slowly. Look, this is a rapid filling. This is increase more slowly. The ventricle continue to fill with the blood until they are nearly full, and the ECG in this is no deflection ECG, and that the heart sound, there is no heart sound in this phase, and that this is complete the cycle and the start cycle once again. This is important graph coming in exam more than one. This is that due to the mitral valve closures and semilunar valve closure. This is isovolumic contraction. With the opening of this valve is that the ventricular systole, and that this is a pressure volume curve of ventricle and aorta. This pressure volume curve of ventricle, and at the end of the systole, the aortic valve is the close again, and the aortic valve is close again. This is give us the second heart sound, and the tricuspid and mitral valve once again close. So this is the what called isovolumic relaxation. Mitral valve is open there, give S1. This is important to see that the pressure and volume and phases of cardiac cycle. This again a table, you have to look for it every atrioventricle IV valve, semilunar valve. Which situation of each valve during atrial systole, early diastole, late systolic, and the early ventricular diastole, late ventricular diastole. It's open, relaxed, contracted, close, open. You have to read it, please. See you soon.